So there are some situations where, well, this is kind of like the summary of what I thought would be a good way for us to kind of go over compounded medications and injections. What are the indications for compounded medications? When should we be thinking about it, and when do we use these anyway in practice? And then the review, kind of what is the compounding process? What does that look like? And then the most common examples, of course, in ocular surface disease for compounded medications, as we've discussed previously, is autologous serum and then PRP, or platelet-rich plasma. And then with respect to injections, I think the kind of the more useful things to do, of course, in ocular surface disease is using a little bit of a steroid injection during the time of meibomian gland probing, and VEGF, anti-VEGF injections into the cornea for corneal neovascularization. So we'll kind of try to hit on all of these topics as we go through, to think about what situations sometimes where we need to use compounded medications. This is, I apologize for this is kind of an old version of my PowerPoint. Can you please maybe just load up the recent PowerPoint? So the one that I gave you today, please? And so there are some indications where there's no other thing that's going to take the place of compounded medications, and sometimes in emergencies where when we're taking calls, sometimes on the weekend, we have to get this patient on a strong fortified antibiotic eye drop. There's really no other alternative. And so these patients that will need compounded medications over the weekend, and the example of a patient that might have kind of had some recently increased their contact lens use and has a central corneal ulcer, and you know that you're going to be culturing that patient, but it would not be it's obviously something that you have to introduce using the compounded medication and before you get the result for the culture result, and you have to start the use of the medication. So having a very close relationship with your compounding pharmacy is a huge advantage in these cases, to be able to kind of call somebody at a compounding pharmacy that would be able to make the medication for you and deliver it to the patient on that day is a huge asset, And so there are some cases where that's all you can do is use this compounded medication because it's a medical emergency. But then there are a lot of other, times when we're not using it on an urgent basis. As we know, there are compounded medication use in more chronic conditions. We know the most of the time, the most common one is in the care of diabetic macular edema and age-related macular degeneration, where these injections are used frequently, the anti-VEGF injections, and of course in the use of the treatment of glaucoma. And so a lot of these patients may need to have the compounded version of a medication. That's fine. So, so there are chronic, uses for these medications. Another example of that is in the treatment of blepharospasm, the periocular injections, and so these patients will oftentimes need to have chronic use of compounded medications to take care of, obviously, their compounded, their chronic condition. These are some examples of compounded medications that I use frequently. We've talked about the first couple, and then the Decadron injections into the meibomian gland is something that's I've started doing that very recently. And again, these are the patients that will come in and they'll say, I've had 32 Kenalog injections because I keep getting hordeola and I've had chalasia removed 16 times. These patients that keep having these problems with their lids, and they kind of have lid tenderness and thickening in one region, or when you're looking at it in the slit lamp, you actually see the telangiectasia, and all of a sudden there's a part of the lid that's a lot more inflamed than the rest of it. These patients do really well with a small injection of Decadron, 4 milligrams per milliliter, at the time of doing the probing, at the time that you're in the gland. And so I don't do it on every patient, but for those patients, I found it to be very helpful. And then any sort of multiple different concentrations of cyclosporin, which is the most widely known anti-inflammatory immunomodulator. And so compounding pharmacies can increase the percentage of that cyclosporin. For some patients, that might be refractory to the most common percentage. And then I often use Helon and Predhelon. And of course, when we're using Predhelon or any other compounded steroid medication like dexamethasone, these diluted steroids, the conversation about the potential for the pressure to go up and cataract formation is very high. Is something that you should discuss with your patients. And a lot of these patients, I think it's okay to use a steroid drop on these. It's an inflammatory condition, and I think it's okay to use the anti-inflammatory medications as rescue medications. But of course, you have to develop that relationship with the patient where you feel like they're going to comply. But I think it's okay to use a diluted steroid once every couple of weeks during that phase where they might be flaring up. But it's equally important to, of course, keep following up and make sure that your hunch was accurate about how compliant that patient is. And every time they come in, ask them, kind of really ask them how frequently they're using it. And that could be just an indication that you need to be doing something that's more aggressive than just kind of using diluted steroids. Tacrolimus, topical form, I find that to be a gel. I find to be very helpful for chronic allergy patients as a lid ointment. There's also topical form of tacrolimus that I haven't used frequently, along with androgens. I've used, there's a handful of patients that I've treated with androgen drops, but really haven't done significantly better where I started using it more frequently. But I do use all of those others more frequently. Anti-VEGF injections, as I mentioned, into the cornea for corneal neovascularization. And then, Scott talked a little bit about this yesterday, these patients that get these periorbital blocks for corneal neuropathic pain, bupivacaine or lidocaine, and then have them back. And if they felt that they had some improvement, they combine it with dexamethasone for a little bit of a longer time period where these patients actually feel like their symptoms are a little bit better. I have one patient that's going down to Bascom Palmer to get these injections. He has corneal neuralgia, and he feels like he's much better with the combination periorbital injections. So all of these are examples of different types of compounding medications and how useful they are. This is a patient. Can you please play the video? Thanks. So this is a patient with secondary blepharospasm. Okay, so this is him squinting. And so you could, the video basically shows him having a very uncontrolled blink and, blepharospasm right there in the exam lane. And then this is kind of a video that showed pre and post periorbital injections for the blepharospasm. And it's amazing what it does to this guy's blink rate and his ability to have, actually, he's not going to not be very light sensitive. So it can be dramatic improvement in the lives of some of these patients. This is a patient that had secondary blepharospasm. When I see the word blepharospasm in the chart, I think about this is a very chronic condition. These patients get a lot of injections. And so if it's something that is a chronic problem like that, you have to be kind of thinking about the chronic nature and how many times they're getting this, because you will improve the blepharospasm, but also we also have to know with that repeat injections that the blink is affected. Sometimes there might be even a period of time where that blink is not going to be a perfect blink. So you really have to ramp up your treatment for these patients. So it's a chronic problem that we have to kind of be very vigilant with that tear breakup time and the blink time with these patients that get frequent injections, just like our AMD patients. I talk to retinal specialists that'll say, I'm doing an amazing thing for this patient. I've actually improved the vision, but they're very upset with me, and the number one problem that they have is that their eyes really dry. And so if they get these repeat injections and using a lot of antimicrobial drops and prophylaxis, that ends up beating up the epithelium and really affecting their quality of life. And so these repeat injections are something to really be very careful of. You really have to ramp up your ocular surface disease treatment with these patients. So compounding pharmacies in general, there was this outbreak of a meningitis outbreak in a New England compounding pharmacy. This was back in 2012. I don't know if any of you guys remember this, but when I read this, I was like, I don't remember this. Where was I? But 800 individuals were sick, and sadly, 76 patients passed away. And this was just from compounding a typical dosage of methylprednisone for epidural injections. And so I have a lot of patients that have this in their chart. They get epidural injections for all kinds of different back problems. But this is how important a very careful compounding pharmacy is really essential, because that can have really serious complications. And so some of us might think that we are compounding pharmacists, but if you take that drop and you put it with whatever lubricating drop that you can pop off the bottle as the easiest, and put a few drops in there, and then you give that drop to the patient after you've done a treatment, or you put it in your own eye after you've been sleep deprived and you're on a conference on a Sunday. So this is not really compounding. But I did have a patient who was an ER doc that was treating himself with proparacaine and had terrible toxicity. So we try not to fall into those pitfalls. Once in a great while, it's not going to harm anything, but we try not to fall into those chronically. So we're looking at what is a high quality compounding pharmacy. What should we be looking for when we're collaborating with these folks? So they have to really have a strict adherence to their manufacturing guidelines, good manufacturing guidelines. They have to have very clearly written protocols with each step very clearly defined, and their strict adherence to aseptic techniques. And it has to be very clearly indicated in their process what is the filtration process and what is the sterilization process. And so when you're sort of combining, or you're looking for which local, which pharmacy should I really be evaluating and take care of my patients, these things have to be a knee-jerk. They should be able to really answer all of these questions very, very, very carefully. Mathematical calculations have to be checked by another technician or another person and staff member. And this is especially important when it comes to eye care. So ophthalmologic preparations, especially these intraocular injections, have a lot of dilutions. And so a small decimal error really has serious consequences. And so that's another thing that they really have to be very careful with. And as I kind of put up that other slide that showed a very crude compounding of different formulations, these are all the different characteristics and factors that they really carefully evaluate with every medication that is a compounded medication. So this is a pretty involved process. And when we're collaborating with these folks, we have to know that they have a very robust process in place. When I asked my local compounding pharmacy if I could just go and see what their process is like, they're like, yeah, sure, you can come. We need to have your vaccination records. You need to fill out these 3 forms because we have a HIPAA stuff, but we have our own forms for people that are coming to observe. So that level of detail is important. As you know, we kind of talked earlier about these blood-derived drops. And the reason for that, you've all seen that picture before of all of the very rich, diverse, different components of a healthy tear film. All of these different cytokines and enzymes and growth factors and mucins are actually very important for the stability of the tear film and the anti-inflammatory nature of ocular surface protection. With artificial tears, we can not get all of those rich factors in there. And that's why there's been a lot of interest in some of these blood-derived drops, like autologous serum and PRP. And so this is just a graph showing that there's been, in the last 20 decades, there's been a lot of interest in 96 different clinical studies in 46 different, in 22 different countries have looked at blood-derived drops. So there's a lot of interest in this area, and there's been a lot of more research in this area because we're really getting closer to replicating that healthy tear film, not just a lubricant in the eye, but something that has actually all of these protective factors, and it can be used in all of these different areas in dry eye disease, persistent epidefects, neurotrophic keratitis, corneal ulcers, ocular burns. So all of these conditions that compromise the corneal surface. And it'll be interesting to see how some of these compare with new medications that have been recently approved for neurotrophic keratitis. But the main reason for that is they have these growth factors and cytokines. And so that's the magic in these drops. They have these growth factors and cytokines. And so this is what the process looks like. If we kind of have a patient go and get a blood draw, and to get autologous serum, this is kind of there may be some variations in the process, but this is generally what happens. A blood sample is collected from the patient and it's left at, at room temperature for 2 hours without an anticoagulant. And then that blood is centrifuged and sterilized and then diluted. And we want to keep it away from light because of the vitamin A component in the autologous serum. That might degrade if it's in the sunlight, and then of course it expires. This is something that will expire in 3 months if we have to refrigerate it, and it'll expire in 2 weeks when it's frozen. It's 3 months when it's frozen, and then 2 weeks when it's just refrigerated. Now, I think that's probably the biggest key here is that these autologous serum drops, when patients kind of slack a little bit on some of their other drops and they put it in their eye after the expiration date, with autologous serum and blood-derived drops, it's important that they don't, keep the drops outside. They're not frozen or refrigerated, and they're just kind of using them in their eye like other drops. We have to be very careful that they don't do that because this is not just a lubricant or 1 or 2 medications put together. It's a very rich concentration of a lot of very complex different components, and each of those has their own stability factors that we have to think about. It's very helpful for the corneal epithelium. These are patients that have neurotrophic keratitis on QID autologous serum, and you can see the improvement there in the epithelial surface and the decrease in the corneal scar. This is a patient that has the same 17 after 17 days, so it really helps to close down that epithelium very, very well. And pointing to again the components of the tear film. It's not exactly the same. So we are trying to mimic the components of the tear film, but these different components are not exactly the same in the autologous serum or in the blood-derived drop. And there are different features there. So in one of the main things that's sort of is of interest right now is trying to identify all of these different components and knowing, well, because there are some risks in this process, it's not a risk-free process. Is there any value in isolating? For instance, we know that lactoferrin is very high in some patients that have severe dry eye. Can we isolate that and use that alone? And so there are a lot of different areas that we can use this process to kind of fine-tune our ability to kind of improve what else is out there to try to improve try to reinstitute and reuse some of these things that are very helpful. This is just a quick diagram showing you that, as I mentioned before, the tear film is very complex. This was a clinical study that looked at the protein layer, and that also is very complex. In this same study, they identified 600 different types of proteins and 17 different types of categories in the lipid layer. And so that's really astonishing for me that that's the level of complexity that we're thinking about in that tear film. And so it's not just an oil layer, a water layer, and a mucin layer. When we describe it to patients, we're really trying to mimic something or trying to improve something that is very complex. I've always been fascinated by tear firming. and so the tear film, actually, if you take just a sample of a tear film and you just let it dry, on the severe dry eye patient, it'll look very different compared to the healthy patient. And so the tear film itself is very, very complex, and it looks very different in diseased eyes. And so the platelet, PRP is really, it's a fundamental part of the platelets are a fundamental part of wound healing. In fact, that's their job, is that when there's wound healing going on, they're a fundamental component. They kind of stick together and they form a barrier to the leaky blood vessel. And so that's their main job, is to kind of decrease that inflammatory response, and they're actually very widely used in maxillofacial surgery and in orthopedics. I've had microfracture surgery on both of my knees, and I've had a PRP injection in my left knee. And so that's kind of one of those things that really helps me remember that they're excellent in wound healing. And these growth factors and cytokines in the autologous serum are sort of the magic in the serum. These platelet-derived growth factors seems to be the key part in the PRP. All right, so basically what you could imagine there, basically I'm just doing meibomian gland probing, and that's you can actually see that little aliquot there is basically a small amount of the decadron. It's basically the same thing that we saw in our little workshop, but there's a syringe, and after you do the meibomian gland probing, you draw some of the steroid into the gland. We kind of talked about this a little bit earlier, but the only thing I would add to my process there is sometimes I'll ask patients to offer patients Valium, but of course we have to talk about somebody driving them home that day if we're going to do that. And so that's kind of my brief little introduction into compounded medications and injections. And so I wanted to see if you guys have any questions at all. Yeah.
What size of needle?
150 micron is the size of the needle, and it's not a needle. And so this is just the same. So this is not like a Kenalog injection where we're actually using a needle or a syringe. This is actually using the meibomian gland probes, but it's a cannula, and so it's basically it's hollow in the middle, and so you're applying it to the to the syringe. You draw up the decadron, and then you throw away the needle, and you apply the meibomian gland tip on it, and so you're replacing the needle with the meibomian gland probe. Yeah, it's hollow in the middle. Yeah.
Is the Valium for you or the patient?
Yeah. He was asking me if the Valium's for me or the patient. So. All right. So just compounded medications are things that I think we're going to be needing to use. We do need to use these medications very frequently, and the use of some of these injections, I think, will be more and more common as patients, feel better with lid treatment and also some other conditions like corneal neuralgia. But thank you guys very much. Dr. Jake Lang is going to talk to us about glaucoma.